Let's talk about hypertension and why we should control it. Good afternoon, friends. If you don't know who I am, my name is Jessica, and I engage in conversations about weight loss and how to achieve weight loss in an affordable way that honors people's way of living. I believe in equitable, sustained fat loss and health promotion that should be accessible for all. I am also joining you in this journey as I am in the process of losing an additional 6% of body fat after losing 25% of body fat already. Blood pressure is the force of arterial structures created by interplay of flow, volume, and constriction. High blood pressure has been defined by determining the levels of blood pressure that cause target organ damage, morbidity, and mortality as how arterial flow is delivered. 95% of hypertension is primary or essential with no known cause, and the other 5% is attributed to structural, circulatory, or chemical abnormalities. Hypertension is a risk factor for coronary artery disease, heart failure, stroke, peripheral arterial disease, kidney disease, and retinopathy, and therefore present a significant public health threat. The Journal of the American Medical Association had a really interesting podcast that commented on the 2017 guideline change, which promoted the range of blood pressure to be lowered to ensure we manage earlier elevations as a protection for your heart. Specifically in the 2017 ACC and AHA guideline recommended a lower blood pressure threshold for diagnosing hypertension, defining the stages. Well, stage 1, 130/80, and stage 2, 140/90. So you can find it up there, all the stages. Now, there was criticism about this as the medical community had two issues with the guidelines. First, the guidelines were changed due to a single study. I believe it was called a script study, when in actuality it wasn't. It was actually a really robust body of literature that was obviously saying that the sooner we protect our hearts and we protect our organs, the better would be. And the key thing that podcast outline is that the benefits outweighed the adverse effects. The adverse effects were not very high, and this is of course to do with a well patient. Now, the second criticism had to do with the fact that we weren't treating the people that had really high blood pressure anyway, and we're now putting other people in here, and our population of blood pressure-ish situations are going to increase. Hey. But it actually, once again, as per number one, that it was very, very, very important to have that protection of your heart and your organs, and the benefits really, truly outweighed the adverse effects. So why are we engaging in this conversation? Well, due to the fact that both primary hypertension and obesity-related hypertension present a similar pathogenesis, the principle of treatment are the same and are focused not only on lowering blood pressure, but also on normalizing body composition and metabolic abnormalities. Key point, not necessarily weight loss, but fat loss. Cross-sectionally, higher weight is associated with higher blood pressure levels, prospectively baseline weight and weight gain, predict higher blood pressures. These findings suggest that weight gain may pathophysiologically contribute to blood pressure elevations. However, as per stated earlier in our discussion, 95% of primary blood pressure is actually of unknown origin. So there is argument there to be had. But there is value in ensuring blood pressure is within the reasonable range, as I will always remember learning in school that once one system dysregulates, the rest soon follows. So my attempt to actually actively chat about this is to give you a gentle reminder that always check with your physician and ensure there's a conversation to be had with them about blood pressure and how to manage it, whether it is pharmaceutically wise or non-pharmaceutically wise. I would say have that conversation. Is always beneficial to engage in health positive conversation. Have a good one, and we'll see you Wednesday.